All right, we are going to get started. I'll let people in as I see them coming. But hello, everyone. My name is Allie Shipman. I am the Parent-to-Parent Program Coordinator here at the WVU CED. We're all here today for our virtual speaker series on feeding and swallowing. Today, we welcome Cassie Miller, who is the Director of the Feeding and Swallowing Clinic here at the CED. She's a speech pathologist by trade and the assistant professor in disability studies at the WVU School of Medicine. So welcome, Cassie.
Thank you. I think my first question is, does anyone looking for specific information kind of as we talk today, parents who have like specific questions or things that they want to learn, you can unmute and kind of share, or you can put it in the chat, just so I make sure, one, I can answer your question now, or two, that I make sure that I hit on that. And if you're just looking for additional, just all kinds of information, we can do that too. Okay. Roxanne, did you unmute? All right. She's like, no way, I'm not talking. I'm hiding from your. All right, perfect. So let me share and we'll get started. Over. Okay, so we're going to talk about feeding and how do we look at feeding and what do we do to help when feeding's hard. And we'll talk specifically about our clinic and what kind of things we do to support feeding. All right, so the first thing we kind of see is that feeding starts super early in development. And when we're talking about, what's happening in utero, and we're talking about disability, and we're talking about little babies, right at 4 weeks before most people even know they're pregnant, that attachment under your tongue is already formulating. And then little ones start swallowing in utero about 11 or 12 weeks. And sometimes that's when people are starting to tell people that they're pregnant, so that's early. Around 18 weeks, we can see that. When we're doing scans and things, we can see swallowing in utero. And then not until 32 or 34 weeks do we see all those pieces kind of come together to create this full swallow. And so what happens for our kiddos who are born earlier than that, all those pieces haven't really come together yet. And so sometimes that's where we'll see the beginning of feeding difficulties come, or for our preemies who are born, 21, 22, 23 weeks, they haven't had that full piece yet. And we know, 36 to 37 and beyond is that full term. So yeah, little ones are working on swallowing when they're teensy weensy. And when we're talking about swallowing, there's so many things that can happen during birth that affect swallowing, right? And I think as parents, as moms, as caregivers, the first thing we're meant to do is feed this baby that they hand to us. And when it doesn't go exactly right, that's hard, because that's the one job that we're supposed to do from the beginning. So things that we look at when babies are born, they give them scores. Right at birth and then a minute after, and they look at things like, how are they breathing? What color are they? And so when those scores are different than what we would expect, that can affect feeding. What their birth weight is, how they're growing. Did they need oxygen, right? Were they on a breathing machine of some type? Did they have to stay in the NICU? Is there another diagnosis going on, right? So is there a cleft palate, Down syndrome? Was there exposure in utero to something? Is there a physical difference of some type? Was anything going on when mom was pregnant, right? A complication of some type. Did she have high blood pressure? What kind of prenatal care did she get? What kind of prenatal medications, right? What kind of birth did we have? When we have babies who are born via C-section birth, they don't get exposed to all the things in the birth canal that babies that are born vaginally are. So from birth, their GI tract is a little bit different, right? Did they need a vacuum assist? Did they have to be pulled out with forceps? How early were they? Were they on time? And then how are they being fed, right? And so we think of babies all just feeding the way we expect them to, but sometimes moms try breastfeeding and it doesn't go well, or a baby needs an NG tube in their nose to help them get fed. Sometimes they'll need an IV for eating. So there's lots of different things to consider when babies are first born, right? And that's my little niece there on the right. And swallowing is a big test of, are we going to survive, right? That suck, swallow, breathe is kind of that first test of like, how's this baby doing? Um, and without medical intervention, some of these kiddos didn't live that long, right? Now we have interventions that we can help save them and give them support. That's how we determine what growth is going to look like. And that's how we determine what health is going to look like, of how we're eating and how is our body getting the nutrients it needs. When we're looking at criteria for discharge from the hospital, American Academy of Pediatrics says, feeding is one of those big pillars that we look at. How are we going to let someone go home from the hospital? Are they meeting those standards, right? And we think all these skills are just there from birth, right? And you can see this.
Okay. That is distracting.
Say hi, Mama.
Oh my.
Cough it up.
You got it?
Yep, get it out, buddy.
All right. And so in that video, you can tell that the expectation is that that baby is going to cough up whatever in their airway, right? They were using a bulb syringe. And they wanted to intervene. That's my sister. Don't tell her I showed the video. Just kidding. She knows I showed this video. But I was like, no, stay back. Like, let her do it. Let her work it out. But for some kiddos, there's lots of reasons why they can't work that out themselves, right? And that could be that they had to have oxygen. Their muscles are different, right? Their brain might be running things a little bit different. Maybe they're withdrawing from a substance. They might be premature, or maybe they had some kind of a birth trauma, right? And so again, this is the ideal, that this baby comes out and it has some gunk and they're just able to kind of cough it up. But it doesn't always go that way.
Okay. That is distracting.
Say hi, Mama.
Everyone's
Oh
pretty
my.
calm because they're
Cough
just
it up.
expecting her to
You
do
got
what she's
it?
supposed to do.
Yep, get it out, buddy.
Okay.
You don't have to keep watching. It's very cute. All right. So we know that sometimes there's challenges in feeding. How often does that happen? 10 to 45%. That's a really a vague number, but different studies say different things, of just typically developing kiddos have difficulty with eating, right? For our preemies, it can be up to 70%. Our kiddos who have another developmental delay of some kind, 70 to 80%, right? I've also seen numbers that kiddos with autism spectrum disorder, on that spectrum, is up to 90% of difficulties with feeding and eating, right? So that's about 2.3 million kiddos in the US. And some diagnoses we know come with specific feeding differences, like Down syndrome, right? They're aspirating oftentimes with feeding. So we want to be really careful when we're looking at certain diagnoses, when we have information to kind of back up what we're looking for. So lots of kids. All right. And so we think about feeding, right? And we're talking about, oh, it's just eating. What can that impact? How hard can that be? Especially for a family who's working on helping their kiddo eat, or a provider who's trying to give some support. Lots of things can result from food difficulties. And if you kind of close your eyes and think about our culture and celebration, every celebration that we have revolves around food and eating. If it's your birthday, you have cake. Someone gets engaged, you have an engagement party. It's Halloween, it's Christmas, it's whatever it is, and involves eating. So it's not like you can avoid it. If you're having a hard time riding a bike, just like don't go where there's someone riding a bike, right? But eating is all the time. And so emotional dysfunction kind of happens for both the kiddo and their family, and overall decreased quality of life. And families report when they're working on multiple skills. So if they're working on feeding, and they're working on walking, and they're working on talking, that the care for feeding is the most fractured. So they have a really hard time figuring out who to go to. And so that overall quality of life gets affected when they're not getting kind of the services that they need to support their family. Failure to thrive or failure to grow, altered growth, and that can be a slower pattern, their own pattern, decreased overall neurodevelopmental outcomes, right? So are we achieving the goals that we want to achieve? Stress, poor nutrition, constipation, dehydration, being really isolated, right? When your kiddo's eating differently, sometimes that becomes isolating for families. Decreased autonomy for both the kiddo and their family, right? When they're talking about decision making and what restaurant can we go to, and if there's food allergies. And then fatigue, right? Mental fatigue, physical fatigue, lots of things can happen when we're talking about feeding. And so just some quotes from families, right? And some of these kind of stem from when there's rigidity around diet, right? Tan and crunchy is where we live. We see a lot of our families who kiddos are like, these are the foods that I love. Why would you mess with them, right? And so tan and crunchy. The greater the feeding challenge, the greater stress for the parent. I think that one's interesting, right? One caregiver talked about her parents and how she tried to help them understand the difficulty she was experiencing parenting two young children, both with unique special needs. The grandparents lived about 45 minutes away, and one day they arrived and she just gave her dad, like, here's your Tupperware of warm vomit because the kiddo was vomiting on the way there. So was it reflux? Was it that they didn't tolerate a feed, like something that was happening? And the dad was like, the grandfather was like, well, what do you mean? She never throws up in the car for us. It's not stressful for a family when they're saying, oh, you must have done something to cause them to throw up, because for us, they would never do that. Another parent, I don't really care about judgment, but I think for other parents, it's that perception that being a good parent means you feed your kid nutritious food. And when you're not feeding your kid nutritious food, you feel like a bad parent. A lot of parents report that to us. Like they feel bad that their kiddos are only eating these certain things. And we all have to start somewhere. And let's be fair, if someone's watching us eat all the time, I'm sure it's not nutritious choices all the time. Mackenzie, my colleague, keeps me stocked up with candy that I keep in my desk drawer, and I just pull it out and eat it as needed, right? No one's here to judge me though. If he can make better progress at school or with his teaching assistant or babysitter, mommy will leave for 2 hours so you can try a new food. And so that's that mom saying, you know what, I want to be there and do the thing, but you're doing better with these people, so I'm going to step back. And that's really hard, right, as a family. And so we work really hard to make sure that parents are integrated, but that's a mom just like trying to figure out what to do. And this last one sticks with me when we're talking about treatment, right? I mean, did I have my husband hold his head still while I shoved food in his mouth? Yeah, sure. Did it work? No. Did anyone feel good about the situation? Absolutely not. Will ever do it again? No. But if you have a kiddo that's not eating and you don't know what to do, right? You kind of get to that point where you're just going to do anything. All right. Make sure you stop me if you have a question or a thought. Jump in. I do well with that. All right. And so then Haley Stream is a big researcher with families too. And so these last couple, and then we'll move on, right? And so if you think about a family, and I empathize with families when they're working through feeding challenges, but his feeding problems have just been awful. You know, the whole taking an hour just to get him to drink an ounce. And on top of that, the screaming, especially when you're doing your best, takes everything you've got and leaves nothing for yourself or for anybody else. And sometimes you do the hour and then you vomit. And so then you're back to where you started from, right? All day long, I think about, what is he going to eat? Is it enough? Right? Since she got the diagnosis of failure to thrive, I'm always thinking about some aspect of her. This week I had doctor's appointments, feeding therapy, physical therapy, and a genetics consult. Last week it was being on the phone for hours, trying to figure out if the special formula was going to be covered by the medical insurance. So just lots of aspects and parameters to when you're thinking about feeding, right? All right, so let's talk about some of these milestones that we see in feeding, right? We think of infants not doing a lot of things, but they actually do a lot, right? They cry in a loud, clear voice. If they're not crying in a loud, clear voice, it starts making me question things about feeding. If it's gurgly, are they not clearing their airway very well and some food's kind of laying in there? If they're not crying to say that they're hungry, why is their body not letting them know to cue you to feed them, right? That's a difference that I look for. Different pitch and loudness, right? They can find sound, they startle, they get soothed by a calming voice. Cry to communicate needs. When we talk about feeding, we talk about the senses, right? We can taste food and we can smell food. There's also this sense called interoception that our body lets us know when we're hungry. And sometimes our kiddos who are really premature or they have a brain difference, they're not able to tell you that. So they get underfed or overfed because they're not crying to let you know what's going on. They're smiling, they're cooing, they're laughing, they're doing all kinds of fun things. All right, for feeding milestones, what are we looking at, right? Birth to 3 months, their anatomy looks different. Their tongue takes up a whole bunch of their mouth, and that's what they should be doing, right? Their jaw is in a more recessed backwards position. They're using their tongue in a forward and backward motion, right? We're really focused on them being stable, right? When you're feeding a little tiny baby, you need to make sure they're like stable. As they get older, you can kind of fling them around and it's fine. They're semi-reclined, right? Because they don't have the muscle strength yet. If you sat them all the way up and started to feed them, all the food would just come back out the front, right? They still need that positioning to be backwards. But they're able to coordinate, suck, swallow, breathe, and maintain things like their oxygen level, and their heart rate and their temperature, right? All those things kind of go together. 3 to 6 months, babies are starting to kind of bring their hands together on breast or bottle, whatever they're eating from. They start to get introduced to a spoon. American Academy of Pediatrics says 6 months of age, and they start suckling some things from a spoon, right? Their tongue starts to move up and down, right? And as early as 3 to 6 months, we can start seeing a little bit of a delay when baby's tongue isn't moving up or down, right? Sometimes we'll get kiddos that are 7 or 8 years old and their tongue hasn't started to do the thing it's supposed to do yet. So that's something we can work on, right? They're still kind of back a little bit reclined. And then when we get to 6 to 9 months, This is when kiddos are finding things on their tray, right? You would expect them to pick things up and bring them to their mouth. They're more upright. They're not biting and chewing yet, but they'll close their teeth and open it back up again, right? And it really mimics if there's a little tiny baby and you put like your finger in their mouth, they'll kind of close, they'll clamp down a little bit, and that's what they're doing. So it's not chewing, but they're learning to figure out like, wait a minute, I have control here. They're closing their lips to strip things from a spoon. A big, huge one here is they're starting to move their tongue side to side. And when you think about moving from purees to foods that have chunks in them, that happens in that 6 to 9 month range. Sometimes kiddos really get stuck here, and it's because they haven't started to move their tongue side to side. And if you think about eating any kind of food that has chunks in it, like if you take a bite of soup or you take a bite of cereal and milk, if you don't move your tongue side to side, the food either one slides down the back of your throat or two just kind of gets stuck. So this is a space when tongue movement gets different, that we see kiddos get stuck sometimes. They'll start holding a sippy cup if given. Usually they just throw it on the floor, but we keep handing it back to them, right? Starting to do some mashed up table foods, right? Starting to grab the spoon from people, and they're starting to pick some stuff up off their tray, right? So they're using a really wide grasp to just rake something off. They're not using that fine pincer. They're not Palmer yet, but they're using a big grasp. All right. And then 9 to 12 months, they're starting to pick things up with their fingers, right? They're taking a bite off something like a cracker, right? Oftentimes in feeding clinic, we'll read our feeding history, and the foods will be things like chicken nuggets and Doritos and French fries. And I always ask students, do you have to chew this? To which they say yes, but you really don't have to chew it, right? You can kind of gum it. You can just leave it in the roof of your mouth and mash it up. And so sometimes with chewing, we start to see that emerge 9 to 12 months where kiddos are having a hard time with chewing. They're starting to be okay with some texture. They're specifically reaching out for the spoon, drinking from a cup. And they're really exploring what they're willing to eat, right? By 12 months old, if you take a kiddo who's checking off every box in feeding, and this is a picture that doesn't typically happen, right? Because normal feeding, what is that? Everybody does something different. They would eat most of what's on the table, right? And when we move to that 12 to 18, they're closing their mouth when they're chewing things up. Around 13 to 15 months, maybe 17, they're having some good success with that spoon by themselves. They're holding their cup, their bottle, right? Bottle weaning around 12 months is what we would expect. And they're doing most table foods, right? No raw vegetables, right? We're not giving them globs of peanut butter or nuts, anything like that. But most things on the table you can make into a form to give to them. 18 to 24 months, they're really feeding themselves, right? You set them up in their high chair and kind of walk away, and they're doing what they need to do. Not walk far away, but you're sitting at the table and they're in their high chair, right? They're more precise with their eating and chewing, right? They can chew something up specifically. They're eating whatever they find, right? Including like little fuzzies off the floor and whatever. So the eating is not stuck to just food. They'll eat whatever, dirt, rocks, whatever. 24 to 36 month, they're kind of holding a cup with one hand. They're feeding themselves. They're starting to poke things with a fork. And again, they're eating all kinds of different things. So that's if we paint a perfect picture of feeding, right? And everything goes exactly how we would expect. But there are also some red flags, right? Things we see that I'm like, I'm going to think a little more about that. The first one is skill regression. So a kiddo could do something, and now they're not doing that thing anymore. And that can also mean that they were eating a bunch of different foods, and now they're not eating those foods anymore, right? A lot of kiddos around 6, 9 months, they're eating every baby food that exists, right? And then all of a sudden they hit 12 months, they hit 18 months, and now they'll eat like one thing only. That's a red flag to me. Meal times that are longer than 30 minutes. We'll have families that are sitting at the table for an hour, 2 hours, 3 hours at a time. On the flip side of that, sometimes meals will just take like 5 minutes, right? So 5 minutes is quick. What's happening in that 5 minutes? Poor growth or failure to thrive. And I always want to make sure that families understand that that's not ever a judgment on their parenting or how they're caring for their kiddo. That's a clinical cue for me to know like how are they gaining weight, things like that. Difficulty transitioning from one milestone to another. So maybe they're 18 months too and they're still using a bottle. Maybe they're not able to use a spoon at 12 months, 18 months. After they're a year old, they're really just drinking milk or Pediasure and not any solid foods. Coughing, choking, gagging, drooling, kind of at any time, right? We expect kiddos to stop the drooling around 9 months, and then obviously coughing and choking shouldn't be really occurring that much. Coughing sometimes is protecting your airway, but choking, always a red flag. Once you introduce a spoon, right, that they're not having success. So if you introduce the spoon at 6 months, then obviously we'll give them some time to have some success, right? Not accepting any table foods once you've introduced it for a period of time, right? So if you introduce table foods at, 9 months, 10 months, and by a month or so later, they're still not accepting anything, a red flag. History of severe reflux. And we're talking about that. We're talking about gastroesophageal reflux disease, right? Because reflux happens for about 80% of babies, but we're talking about the reflux when kids are vomiting and they can't keep food down and weight is hard and they're getting rashes and things. History of pneumonia, especially right lower lobe pneumonia, and then spitting, vomiting during meals. Also, if a family just feel like mealtime is a disaster, that's a red flag to me, right? If they're like, it's just hard, they won't sit, like they're not eating the same thing everyone else is eating, it's taking forever, they seem like they're struggling, that's always a red flag to me too when families describe meal times like that. All right. So when do we work on feeding? As a speech therapist, I kind of look at a couple different things, and the World Health Organization came up with this framework for feeding, right? Because we have to define everything. Why? Because we have to bill things. And so all this stuff stems from us having to put some kind of code in, right? But impaired oral intake that's not age appropriate and is associated with medical, nutritional, feeding skill, or psychosocial dysfunction. So what does that mean? There's 4 things we have to think about. The medical, right? Is there something going on medically? Is there another diagnosis? Is there autism? Is there a cleft palate? What's kind of happening there? Psychosocial. So is the eating impacting this kiddo's social skills? Well, we just talked about that everything in our society is kind of circled around eating. So yes, 99.9% of the time it's impacting social, right? Feeding skills, what is hard for them, right? And then nutritional status. And that includes weight, that includes growth, that includes vitamins, minerals, all those things. So this is where a team approach, we're going to talk more about that, really comes together, because assessing nutritional need is outside my scope. So I have a dietitian on my team who looks at that. All right, so that's the technical part, right? And so we work on a team, interdisciplinary, right? And so there's different people. Why would we work on a team like that? Number one, evidence, science tells us that collaborating is best. And we know that anytime we work together on a team, it's better, because you might see something that I don't, I might miss something, right? And we talked about that families really think that feeding therapy is not well organized. So we're trying to get better at it. We're trying to work as a team. And we're doing an eval. We always look at kind of medical things, what's going on, sensory needs, right? How are they feeling around eating? How are they able to regulate and exist in the space? What skills do they have, and what behaviors are happening? And remember, a behavior is any single thing that we ever do. If you are answering an email right now, that's a behavior. If you scratched your head, that's a behavior. How you're sitting is a behavior. So we don't mean in negative behaviors. We mean what's happening around eating, around mealtime. All right, and so here's some of our team members. We're in there hanging out. There's some students, right? And so we have a developmental pediatrician on our team he's dual board certified, so he's also a peds neurologist. We're lucky to have another peds neurologist on our team. We have a dietitian, and so the dietitian really looks at a food diary provided by the family and talks to the family about what exactly is this kiddo eating, right? And she's able to look at calorie needs and what calories needs are being met. Are there deficits in different vitamins and minerals, right? A speech pathologist like me. So I look at how the kiddo is manipulating the food, right? How are they getting it to their mouth, and what are they doing with it in their mouth once it's there? Also, is the food going the right way, right? We can eat it really well and we go to swallow, and then sometimes it goes the wrong way. So we're looking at that as well. I don't mean to look at language, but I always do, because it's just kind of innate in me as a speech therapist, right? We have an OT on our team. She looks at a lot of motor things. So how is the kiddo holding themselves up in the chair? What supports do they need? How are they using their hands, their extremities? What's their head control, shoulder control, girdle, that kind of trunk? What does that look like? Physical therapist. We have a team member who's a physical therapist, and she kind of looks at the motor piece too. What supports do we need? What's the quality of the motor movements? How's that happening? Behavioral psychologists or psychologists will tell you kind of what they see around mealtime. So what's kind of happening before mealtime, during and after. And some of that is things like, oh, how is mom reacting? What language is mom using? What words is she using? Are they bargaining? Are they Everyone's stressed out. Like, what does that look like? A board certified behavior analyst can also come in and kind of look at what's happening with behavior and what's going on during mealtime. Social worker, right? Some people freak out because the social worker comes out. Our social worker comes out to really talk about what supports does the family have, right? Who lives nearby? Who lives in the house? Is there anything we can help you get access to? Extended diaper program, or do you need children's special health care needs connection? So that's why our social worker is there. And then the biggest piece is the family, right? That's the biggest part of our team. They kind of help us decide clinically what we're going to work on and kind of tell us their concerns. And what we see in clinic is just one snapshot. They live that every day. And so family's super important. All right. So what do we do, right? What's the speech therapist do, right? We play a central role in assessment, diagnosis, treatment, right? All those things. And we get to do fun things like education and research, also admin, like paperwork. Ew. But as the speech therapist, that's what I'm looking at. All right. And so what are we going to do for a kiddo when they come in, right? Like there's this kiddo and they're having a hard time with eating. Like, where do we even start? Usually it's playing and getting the kiddo to not want to run away and hide from us. It goes one of two ways. Either they want to play with us so much that we're their best friend, or they run away the whole time, right? Because they're like, no way, Jose, you are not a friend of mine. So I look at their oral peripheral. What does that mean? What are their lips doing? Their jaw, their tongue? What's their forehead look like? What's their posture? Are they drooling? Is their face symmetrical, right? When they stick their tongue out, is it going straight? Is it going to the side? Also, we have the family show us what eating looks like, right? Set up exactly what you do at home and show us what that looks like. Sometimes kiddos need a swallow study, right? Where they go to the hospital and they eat on x-ray and you make sure they're safe. And so that's not something we do here, but we recommend them. We look at how they're sitting. We look at, do we need to modify a diet, right? So maybe they're a little bit older, but we need to cut things up in smaller pieces, right? Maybe they're doing baby-led weaning, and so they want bigger pieces. Oral motor treatment, like how do I help you move your tongue in the right way? How do I get your lips to do what they need to do? And then behavioral strategies, and that can be as simple as putting kind of a plan in place that people sit here, this is where you come to eat. You always eat in the same place, eat at the same time. Sometimes it's really simple strategies. All right. And so this is if you would go and have a modified, that's the swallow study under x-ray. You can see teeth, right? And you can see the spine, all the things. This is your epiglottis, right? And so when you take a bite of food, it's meant to go one way. And if it goes the opposite way, then we know that it's going into your airway. And so some kiddos, when we can hear, we talked about earlier, them not having a clear voice, it's kind of gurgly, or maybe they're getting a lot of colds, a lot of runny noses, they're coughing a lot, then sometimes we'll send them to Ruby to get this study so we can really see what's happening. But again, this is just a snapshot. So typically what happens is they go there and one of two things happens. Either one, they swallow fine, which we know typically that's not happening because we're hearing them cough all the time. Or two, they go and they give them all this food that they usually won't eat. And guess what happens? They also won't eat it. So then they send it back and they say, hey, this kiddo wouldn't do it. Well, right, I could have told you that. Give them a food they like, right? So sometimes they're trying to get them to eat new foods and that doesn't go very well. All right, so how do you know that the feeding treatment that you're getting is kind of what you should be getting, right? What's that vibe you get as a family member, as a caregiver, right? If the trouble is with feeding and eating, therapy should look like feeding and eating, right? Sometimes you'll see things that are different methods of weights and blowing straws and things. And if you're working on feeding, it should look like you're working on feeding, if that makes sense, right? Using developmental milestones as a goal, right? And as a guide. Sometimes we'll get kiddos who are 8 or 9 years old and their feeding skills are kind of at 6 months. I can't skip everything and expect them to be going to a pizza party with their friends and eating pizza and salad. Like I need to figure out like, where are we at so we can go to the next thing, right? And it doesn't mean that that the family should feel bad or have any doubt that we're going to get to where we need to go, but we need to start where they're at, meet them where they're at. And that's kind of the next point, meet them where they are and build goals from there, right? Positive associations with food, right? If you have a kiddo who's medically complex or has had a long hospital stay, things that happen around their mouth are often bad. They're being suctioned. They're given meds. People are wiping their mouth out with toothettes. They're having their teeth brushed. Just oftentimes food is not ideal. If you have a tummy ache a lot, then sometimes that association with food is that, oh, my tummy's going to hurt because every time I eat it, I feel yucky. So we really work a lot with creating positive associations. A lot of trauma can happen for our kiddos who are medically complex or having a hard time with eating. Again, because eating happens like all day. It's not like, oh, when you go get a shot, it's really hard. No, eating happens multiple times every day. So if it's hard, you're getting all those associations that aren't ideal. All right. There's all kinds of doodads when we talk about feeding. And so when kiddos come to see us, they usually leave with some kind of doodads, assistive technology for feeding, right? And so you'll see that bear cup in the top, and that does a lot, right? It helps us with straw drinking so they can get their lips in a circle. Also, if they're having a hard time sucking from a straw, you can squeeze it so the caregiver or parent can control that. In the top right-hand corner, you'll see that little loop on the spoon. Sometimes grasping things is hard for kiddos. So you put the loop on there and they can scoop their hand through. On the different colored cups, drinking from a open face cup is scary because it's going to bump you in the nose, right? And it's coming right at you. Those are cut out so it's easier to see. We can help them with their jaw and their tongue. And then the official technology of all feeding clinics is the maroon spoon. That's the technical name for it. I don't know another name. And it really helps because it's flat. And so it's easier for kiddos to pull food off of, right? Instead of a real deep spoon, they're just able to pull the food right off. You can also help them position their tongue. There are so many different assistive technologies for feeding. I could show you a bajillion, but different kids need different things. And so know that that's always individualized on kind of what they need. All right. So why is feeding and swallowing and eating hard for some kids? And this is a model that we use in our clinic, and I'll just explain it briefly, but you can see that medical status and those psychosocial factors kind of encompass everything. And that's all of us, right? If we're not feeling well, if we're diagnosed with something, if we have a cold, if we're on a certain medicine, right? That really affects every single thing that we do. And for some of our kiddos, it might be that they have a diagnosis of a food allergy or autism spectrum disorder or global developmental delay, whatever that looks like, right? And that impacts everything with eating. The other is those psychosocial factors, and that's kind of a fancy way of saying like who's in your space and how's it going, right? Is it that mom and dad have opposite schedules, right? And so different people are feeding them a lot. Is it that maybe the family doesn't have access to a table where everyone can sit? Is it that the family, everyone's a picky eater, right? And so they're trying to figure out how do I help my kiddo not be a picky eater when everyone's a picky eater? Things like access to services. Does the family have a car? Do they have insurance coverage? Those kind of all fit, and those always impact everything. And then there's development. Where's that kiddo at? We just talked about developmental milestones. So where are their feeding skills at? Where do they need some support? What does their language look like, right? How are they able to tell us what's kind of going on? What's hard for them? Where's their motor skills? So we look at all kinds of development. Social emotional development is a big piece of that too. Are they able to get upset and recover? Are they learning how to be upset and be okay with that or communicate that, right? Behavior. So again, behavior is every single thing we do. If every time they come to the table, they flip the table, that's a pretty obvious behavior, right? They're flipping the table over. They must not like this. But sometimes there's other behaviors. Our team will often see kiddos that parents or caregivers or other therapists will say, they will not do this. They will not chew. They will not try new foods. They will not do these. And it looks like a behavior, but what we really find out is they don't know how to do it, right? And so then that goes to development. And so sometimes really looking closely at behavior will help you figure out what's really going on. Behavior can also be, do they get sweaty, right? Are they turning red? Does their heart rate increase? Do they run away from the table? Do they cry? Do they vomit? Do they gag? What's mom and dad's behavior look like? What's aunt's behavior look like? What's grandma doing, right? Have they trained the dog to come and like eat all the food they drop on the floor, right? So there's lots of things to look at for behavior. And the other one is sensory, right? And so 90% of the kids that we get referred because they're having sensory processing disorder. That's a big word, and maybe 3% of the kids we see actually have sensory processing disorder, right? Because we all process sensory things differently, but that doesn't necessarily mean it's disordered, right? And so I look to our OT. Dr. Burt will kind of really assess them for sensory processing. Sometimes it's that they don't know how to regulate in the space, or they've never been exposed to this thing, or it's kind of weird, but we have to work through it, right? And so sensory can just be how we exist in the space. How are we regulating? Like right now, The lights in here are kind of bright, but I can work through it. But for someone else, they might be so bright that they can't work through it in the space, right? Like the back of my jeans is kind of like itching me, but it's okay. But for someone else, that might be incompatible with them being able to sit and work through a meal, right? So how do we kind of make the meal tolerable to them by also we're going to honor that it's hard, but also say like sometimes we have to work through some of these things. And then right there in the middle is where we want to be as a team, and we try to bring the family in there with us too, right? We're not going to look at one single piece. We're going to look at all of feeding, and that's sometimes the key to figuring out why eating's hard, right? What's kind of going on. All right. And you can see we do a chart review for all of our kiddos. This is kind of, we draw one every week. This is what it looked like when we went through the chart for one of our kiddos, right? And so you can see psychosocial things, right? They were in daycare, right? They had a brother. The family has a history of anxiety, right? They were in birth to 3. Those are kind of all the psychosocial things. And then on medical things like they've been to the ENT, right? They snore, they wake often, and then development's in there. And so that's what it looks like. This is all going through my brain when I'm thinking about feeding. So lots of things to consider. All right. Disordered feeding, like what does that mean? It can be that you're having a hard time with the physical eating part, right? It can be that you're selective on eating, right? It could be ARFID, right? Avoidant restricted food intake disorder. So some foods are safe and some aren't. And what does that result from? Like, why do these things kind of happen? That your mouth just isn't moving how it's supposed to. Lots of food allergies, and that can be eosinophilic esophagitis, right? Where it's kind of an immunity-based food allergen. It could be FPIES, right? So that's a GI allergy. It could be our typical food allergies that you go get skin tested for. Food allergies is a huge one for food selectivity, right? Trauma, what happened? Were you in the NICU? Did you vomit? Did you get really sick? Medical diagnoses, and then those psychosocial pieces. So we kind of get a big circle of what's going on with feeding. Right. And so let's kind of go through a case of one of our kiddos here. And so this was Jacoby. So he came to visit us, and you can see we're in clinic. Everyone's doing their thing. All those little tools we talked about, see the official maroon spoon is laid out. And we have students and trainees who are helping out. Mom's in the background. You'll see her as we go along. So what did we find out about Jacoby at the beginning? Underweight, born at 37 weeks, so pretty much full term, in the NICU for 3 weeks. He had a tube in his nose when he was in the NICU. He was getting PT, OT, and speech services. He wasn't able to smell, but no one really knows why, right? And so was it that he didn't recognize what smelling was and didn't report that, but he had good language, but he just, from what we know, couldn't smell. Tonsils and adenoids had been removed, right? He had infantile scoliosis. So he had multiple braces. I think that back brace was like his 21st brace, because every time he would grow, he would get another brace. Low tone, some difficulty with regulating his blood sugar, speech delay, cognitive delay, and some high blood pressure. So a lot of diagnoses to consider for Jacoby. And you can see he's like just hanging out, living his best life. He did not run away from us, which was good. He wanted to play. A lot of times we spend time chasing up and down the hallway, which gives me my steps, but also is annoying to the people who were running in front of their office doors, you know. All right. So he was eating mac and cheese, cheese quesadilla, and pancakes. That's it. That sounds really delicious until you do it every single day. And then your insides are like, wait a minute here. We need some other foods. The goals for the family is that they could add to variety and texture, decrease choking and gagging, and improve self-feeding skills. And what we found out when we assessed him is that he wasn't choking, he was gagging. Gagging is usually a behavioral response to feeding, like, oh, I don't know what to do with this, I don't like this. And so just educating families on the difference between choking and gagging is a big one. Other things, it was taking him about 45 minutes per meal. That's over our 30-minute threshold, so that's a red flag. He would only feed himself these 3 foods. If someone wanted him to eat something else, he wouldn't do it, and he wouldn't eat at school. So mom wasn't able to work because she would go to school to feed him all his meals because he wasn't feeding himself at school. Chewing was hard, cup drinking was hard, and then he refused and gagged with all new foods. So kind of lots of red flags when we're thinking about that, right? So cup didn't get that. Gagging, refusing, lots of red flags for our friend Jacoby. All right. So everybody came in and we're like, okay, what's going on here? What are we going to look at? The physical therapist made sure that his brace was fitted correctly, right? Number one, can you breathe in your brace? Super important, right? It's not pinching you or too tight, anything like that. Social worker really worked with this family on deciding what their needs were. Mom was really anxious. She would admit that. And so anxious parents have anxious kids. And so some of that was kind of feeding over into meal times because mom was feeling really anxious about, is he going to get enough food? What's going to happen? Is he going to feed himself? Like, I don't want to go to school every day, but I have to. A lot of that. Dietitian had a diet record of 3 days for Jacoby to check out and analyze. We watched him eating preferred food and we did an oral periph exam. So we looked at his lips and his tongue and all those things. He needed a little bit of a behavioral approach. And what does that mean? We asked him to do something. We put a demand on him for eating, like, hey, can you touch this carrot? And then he got to do something he wanted to do, right? And so over time, touching the carrot was fine. And then we went to like, oh, can you pick the carrot up? And so sometimes a behavioral approach just looks like that. What plan do we have for rewarding this kiddo for doing something that's hard, right? Because eating sometimes is really hard. If we went in and said, eat this carrot, you're not getting up till you eat, we would probably still be sitting there. He'd be crying, I'd be crying, mom would be crying, and all the students would have already graduated because we'd still be sitting there. Like, right? We have to come up with some other plan than like waiting you out. That's not going to work. We did some gradual exposure, like we talked about. There are some evidence-based theories that we use for like, first you look at the food. Okay, you didn't catch on fire, nothing crazy happened. Touch the food, pick it up. So we work through those. Lots of positive reinforcements. He wanted to bounce on that little like peanut ball. He loved it. So we made sure that we did the just right challenge for him, right? We're challenging him just enough that he can be successful. And then rewarded him just enough that he was willing to go back and do some more, right? So if you touch the carrot and then you get to bounce on the ball for an hour, we lost you, right? Because you don't care about the ball anymore. We're constantly kind of seeing what they want to do. And here's some of his. Oh, or have access denied. On our work computers, Google sometimes doesn't work, but we worked up to Jacoby being able to eat carrots in that session. He had never done that before, so he worked through the gagging and we were able to teach him to start to move his tongue side to side because what we found is he was just moving it in and out. And so his mom would always say, he won't try this. It's that he couldn't figure out what to do with the food, right? And so mom was so relieved to know that there were things we could do to teach him these new skills. He felt really good about it because he felt safe and seen that we realized that this was hard. All right. So kind of some behavioral feeding, like he was refusing some things, but did have oral motor deficits as well. Also had some vitamin deficiencies that he needed to add new foods to his diet. He was safe to eat the foods he wanted to eat. And we were going to add in new foods, and we based the foods that we were going to add in first on the recommendations from the dietitian. That's how we decided what foods to go first. He was also going to sit and do family meals. Before this, he would cry and gag because he didn't like the food his family was having. And we kind of worked through that. Hey, you can sit here. It's okay. We're not going to make you eat all the foods. And he started adding 2 or 3 new foods a week. So he had a great success. All right. So that's kind of the end of my formal talk about feeding clinic and what we do. And so I was going to go to questions and see if anyone has an example or a question that they have for me about feeding.
There is one in the chat
Oh, in the chat. Perfect.
from Lisa. So
Usually Mackenzie keeps me together on my chatting. Mackenzie. I'm even looking for chat. Aha. All right. Grandson has difficulty controlling tongue and food in his mouth, which leads to choking and throwing up. No particular food, no particular time. He's been working with birth to 3, but this hasn't resolved. He'll be 3 in January. Any suggestions? So, what's that? Lisa. Is Lisa still on? Yeah, okay, Lisa, perfect. So do you know, Lisa, if birth to 3 is doing specific intervention with him during meal times to teach him what to do with his tongue?
Can you hear me?
Yes.
Okay. They had given him a chewy toy because at first they thought that and they still kind of think that maybe the muscles in his mouth are not strong enough, so he tires out.
Okay.
Such as peanut butter. He used to, that's the strangest thing to me is that we didn't see any of this when he had no teeth. But then when he began to get teeth, then he began some of this, displaying this action. So it's the same foods like a blueberry, for instance. It just depends on what day it is. And we fear because he too is now selective in what he eats that he knows that that food choked me last time and I threw up, so I'm not going to eat it again.
Yeah.
So we're down to very little cheese quesadilla is one of his favorites. So I had to laugh when you put that up there, as well as mac and
That's a
cheese.
go-to.
So, obviously we're concerned. He did see a GI doctor recently who said perhaps a feeding clinic. So we are in Putnam County, and I don't know if it's the same type of feeding clinic as what you've just described and gone over. I hope that it is, because that sounds wonderful.
Yeah, and so a couple things. One, our feeding clinic here at the center at the CED is free, and we serve the whole state. And so we see kiddos. He might even be on our list. I'm not sure about that, but we can figure that out. We serve the whole state, and so families come to us, and what our goal is to kind of figure out what's hard and then train his therapist where you live, so you wouldn't have to keep driving from Putnam County, or flip and do like some telehealth. So any of your families who live in West Virginia, or they need a service, they can come to our clinic. Does he have times where he gets tired from other activities, or are they thinking it's just eating?
Just eating.
And typically that's not what happens. Usually kiddos who have a difference in muscle control would be during multiple activities, not just eating, if that makes sense.
Okay. Yeah, he just recently, because I have Googled it until I'm cross-eyed trying to become
Ah,
an unofficial
speech therapist in your heart.
therapist.
Yep.
But he could not, like a lollipop, he didn't know what to do with it. Ice cream in a cone, he couldn't lick it because he didn't know what to do with it. So we've
Yes.
worked on that. And then the left to the right, oh, that was a lot of work between my
Yeah.
son and myself. And he can now move his tongue when we say, move it, mimic what I'm doing.
Yay.
So we're getting there, but it just seems like it's been, because our first red flag was delayed speech.
Okay.
And that led us down this road of Versa 3 and some other things, but it just kind of stopped. But some feeding issues still remain. And like I said, we're just trying to figure it out. So maybe I can connect with you afterwards and figure out.
100%. The other thing that sometimes we'll do is when you're introducing a new food, sometimes it's like the size of a tip of a pen. So like this morning there was a kiddo, and they had vegetables, and we're trying to introduce vegetables. And so literally it was the tip of a pen is what we started with. Oh my gosh, you ate a carrot. Great job. And I'll like lift their arms up and be like, look, you're not on fire. Like no one exploded. It's totally fine. I love how you ate that carrot. Awesome. And move on. And so just
Okay.
start with maybe what's on the table with everyone else, and start the tiniest piece ever. And I don't care if he even tasted it. It doesn't matter at that point. And then the next day be like, maybe we can do 2 specks. Cool. So sometimes the size of the food that you're introducing makes a big difference, especially if he's got his glorious cheese quesadilla right there. And you say like, let's do I'm making this up, one tiny little speck of green bean, and then you can get your whole quesadilla. Boom. Positive association with that food then.
Yes.
Yeah,
Okay. That
but I
makes
would love
sense.
to talk to you more, and I would love to collaborate with his Birth to 3 team and see if we can kind of figure out where the sticking point is.
Okay, great. Thank you.
Sure. Okay. Anyone else? Question, thought, thing? All right. So talking just a little bit more about our clinic and what we do. So we're Fed funded. And so luckily we have funding for our practitioners that's outside of insurance. So we don't have to bill people to come or anything like that. And so people who make a referral are families themselves make referrals, teachers, other therapists out and across the state, the GI docs, ENTs, pediatricians a lot of times will make the referral. And they're for things like kiddos only eat a couple foods, right? Meal times are lasting a really long time. Parents are kind of at their wits' end because they keep offering food and the kiddo refuses. They've been on a bottle for a long time, or maybe it's that are doing Pediasure and now they only want Pediasure and not other food. And so those are kind of some of the reasons that kiddos come to our clinic. Once you make a referral, right? So you make a referral to our clinic and we're thinking about, we're going to see you. Mackenzie, she's on here. Hi, Mackenzie. She can wave. Manages our referral. So Mackenzie will send out a feeding clinic questionnaire. And that questionnaire has lots of detailed information that we're looking for. So it talks about who's living in the home, who made the referral, what did feeding look like as an infant, right? What the family sees that's hard, how everyone's feeling. So part of it is, how does your kiddo feel during meal times? What does that look like? How do you feel? How do caregivers feel? Grandma? Does feeding look the same across all environments? So is the kiddo doing the same thing at home that they're doing at grandma's house, that they're doing at daycare? And some of our kids have really specific rules around eating. So eating at home is this certain thing, right? And then they go to daycare and there's these other rules around eating. And then at school, there's other rules too. So we'll talk about that. We'll ask about that. Also about medical diagnoses and what else is kind of impacting feeding. So things again like cleft palate really affect feeding. Things like muscle differences, if we're talking about trunk control, so high tone or low tone. Has the kiddo been to the dentist, right? So sometimes we'll get kiddos and they're having a hard time with eating, and then we figure out like, oh, they might have a couple cavities, right? Because there's something going on with their teeth and they just kind of need to see the dentist. We also ask about what other therapy is the kiddo getting, right? Because sometimes PT, OT, speech are all kind of going on, but no one's like the lead for eating, right? Because if we all do our parts, it's different than when we get to be in a collaborative space. So it's nice when our whole team is really together there and talking about kiddos. So sometimes the OT will say, well, I kind of thought that the speech therapist was doing this, and the speech therapist will say, well, I kind of thought the OT was doing it, and they don't want to step on each other's toes. And so sometimes it's just everybody having a conversation about, okay, you work on this and I'll work on that. And so we'll also ask about what families are seeing at home, right? So is the kiddo gagging on certain foods? Are they avoiding being messy? Does it seem like they don't know what to do with their tongue? Does it seem like they're getting up and leaving mealtime? And we look at the frequency of that. Is it just sometimes? Is it all the time? And then we really look a lot of what is the kiddo eating, right? Are they eating things you would expect for their age? Do they have to have things cut up really small? Are they eating purees when they should be eating table foods? And our dietitian will often ask for the family to go kind of through a whole day of what that kiddo's eating and drinking. Sometimes we'll find out that they're eating a lot more calories than we thought, or maybe they're eating much fewer calories than we thought. And so she'll go through that and then do height and weight and really figure out what their caloric needs are. So that's kind of the first thing that happens after we do chart review. And then myself and our OT come in and just kind of watch and see, like, what is this kiddo doing? What is the interaction with their family? How is their family directing their eating? Does it seem like they have some ideas on what to work on, or are they just really looking for something to do? Oftentimes we'll problem solve through they're in therapy, but they need a little bit more direction, kind of like what Lisa was talking about. What else can we do to give them some support? We also need to know, who did they already see, right? So a family meeting we had this week, a little one is gaining weight at a really rapid speed, like way more than what her diet would suggest. And so she'll need to go to endocrinology, or she might need to go to another supported specialty clinic for us to make sure that all her levels are okay before we can work on feeding. So sometimes the kiddos will get their chart and we'll kind of review it, and we'll say, hey, before you come to us, let's do these couple things and mark these off. If it's allergy testing or going to ENT, something like that, before they come to us. Or sometimes they'll come first and we'll talk about all those reasons why they need to do that to work on feeding. So they might come and we'll say like, hey, here's ENT, you need to go to ENT, right? We also look at their overall development. So what does speech look like? How are they playing? How are they using their hands, right? How are they interacting with the people in their space? And so our OT and our developmental pediatrician will kind of check out how they're interacting with their environment. And our social worker goes in and really asks the family, where are some gaps in your services? And I always, I don't now, but I previously made assumptions that families will know what kind of services are available for feeding out there, and things like children's special health care needs, or getting diapers paid for, or getting their formula paid for through WIC. And so sometimes we'll make those connections for them to be able to get those services. Non-emergent like medical transport is a big one too. Families drive to a lot of different appointments. And like Lisa was talking about, they live in Putnam County. We serve the whole state. And so families drive a long way to see us. And so we try to make sure that we can get their trip reimbursed if they qualify for that. So that's another one that our social worker will kind of work on. And then we really sit down with that kiddo and try to connect with them and see what's hard. Little nuanced things. I really like how Lisa described how they were working on eating, is what makes feeding therapy work, right? So sometimes you're just working on tongue moving side to side for like 2 or 3 months, right? And for some of our kiddos who are working on adding foods, we always educate families that feeding therapy exists across months and years, maybe not quickly in weeks. Because if you're eating one food and that food's safe and we're expanding you to other ones, sometimes it can take a lot of time depending on what the needs are and the supports are for that family. The other thing we do is once they come and we've assessed all those things, we talk to them about their goals. And I'll often use this line: if you could wave your magic mom, dad, or caregiver wand, what would get easier during mealtime, right? And so oftentimes they'll say, I just want everyone to eat the same food, right? We have families who are making 3 or 4 different meals, and that's a lot and that's stressful. And the reason is there's a lot of time involved in making 3 meals. You have to have a lot of food supplies to make 3 meals, and just energy. Like sometimes you're just tired of cooking all these things. And so we'll talk about those kind of goals. The other thing that really happens at clinic is educating the family on how we get to the next phase of what we're going to do. So if we're talking about, hey, we had a kiddo a couple weeks ago who was using pouches, like the pouches that have the spout on the end, and a pacifier. And so in that, her tongue was only going in and out, in and out. It was not going side to side. And so we had to talk to the family about like, hey, we don't see her tongue moving side to side. And it's because she has this reflex that should go away that's kind of staying in place, right? That suckle reflex of going back and forth that we talked about. And so using the pouch and the pacifier and a straw cup, we're reinforcing that in and out tongue movement. And straw cups are really bottles for adults. You use the same tongue motion. So when we see kiddos who are stuck on a straw cup and they can't transition to like a hard top sippy or a soft top sippy or open cup, oftentimes it's because their tongue's not doing the thing that it needs to do. The other thing with this kiddo is that her palate and teeth and face shape were changing because she was relying on that pacifier, right? And so it was given a lot of education to them about why the extended pacifier use was affecting her. Some kiddos, they can have a pacifier and pouches all day long and it doesn't affect their tongue at all. It doesn't affect their face shape at all. But then other kids, it really does. If I could figure out what kid it was going to affect and which one it wasn't, I'd be like a bajillionaire because I don't know, right? And so it's also talking to families and saying like, hey, this wasn't something you did. This is just what we're noticing now. So here's how we can kind of help this. And so we talked to them about pacifier weaning, and I think they came up with like the greatest idea. They were like, well, who are we going to blame taking the pacifier away from? I'm like, well, I blame the dentist for my kid. So I don't know who you guys want to blame. I don't want it to be me because I want your kid to like me. So they went to Build-A-Bear and they put the pacifier in the Build-A-Bear. And now this little girl hates that bear so much, she won't even go near it. It's like her number one enemy because she knows her pacifier's in there, but she can't get it. But sometimes feeding, you're talking about feeding. Why are we talking about how to wean from a pacifier? Because they're all connected, right? And so now pacifier is gone. Grandma had to go and find, I think, what did she say, Mackenzie? She found like 27 pacifiers in her house, Grandma did. Because she watches her
And
during
then
the
like
day.
in the couch and
Yeah,
wherever else the kids
And-
stuffed them.
Yeah, and I think that the little girl realized what was happening, so then she started like stuffing them in other places because she's like, wait a minute, I see what's happening here. And so it was getting grandma on the same page too. And they were so thankful for saying like, hey, no, like we knew the pacifier like wasn't ideal at this age. She's almost 4. But no one really said like, this is why. And so she was so thankful that we really talked about like, this is what the impact is. This is how we can get rid of it. She's like, it's really easy to say get rid of the pacifier, but we didn't have a plan. So we were just afraid of doing that. And the same thing with the pouches, like pouches aren't inherently bad, but using them only with no spoon was kind of what was impeding her. So now she just squishes it into a bowl with a spoon and it's perfect. So that's kind of one of our success stories, because that family was able to get rid of the pacifier and get rid of the pouches. And now this kiddo is moving her tongue side to side and adding new foods now. The other thing I want to say is once you get the tongue movement or the chewing or whatever in place, that doesn't necessarily mean that now the kid's going to eat every food on this earth, right? So if you're working on feeding or you're working with a family or you're referring a family, be patient to understand that after they have the skill, we still have to add in those foods that previously were hard. So if every time they ate bread, they choked and it was really hard, just because now they can chew doesn't mean they're like all of a sudden okay with bread. Sometimes we'll describe it to families as like you get stung by a bee and you have this huge reaction and you have to go to the hospital and all these things. And then you get an EpiPen. The bee's still scary, even though you have a way to fix it, right? And so sometimes the food is still scary, even though you have a way to work on it, right? No one wants to be epied, right? But there's a solution, but the bee is still like, we're going to avoid the bee. So sometimes our kiddos avoid those foods that were hard, because it was hard. And so kind of working through that, we use the word trauma, not flippantly, but we use it purposefully, because when you're talking about eating and what's keeping you alive and it was not going well, that's a trauma. Another big piece to our clinic is 90% of the families that we work with, we also pull in mental health therapy for the parents, right? And there's a bunch of reasons for that. One is that the parents are stressed out, right? They're anxious over this because this is how you keep your kiddo alive. And so we really normalize the idea that this doesn't come with a manual, and you're thinking about it all the time. And the families will describe that they go to sleep thinking about what their kiddo's eating, and they wake up thinking about what they're eating, and they're like, oh my gosh, they can't go to a birthday party, and oh my gosh, they can't go to their cousin's house and eat lunch because this is hard. And so we really normalize the idea that bringing in mental health therapy will help and support that. Another big one is anxiety during meal times. And so our kiddos can kind of feel that anxiety when it's kind of coming from a parent or a caregiver. And we also really share with them that they're not doing it on purpose, right? It's not their fault. But sometimes if we can get the anxiety or those feelings kind of under control in the family, then that kiddo can kind of feed off that calm energy as well. And families will really say like, yeah, I don't know how to be calm around meal times. And so we'll bring that in, and oftentimes the kiddo goes too, and we have an in-house therapist that we can send them to, so there's no wait and we don't have to worry about them waiting months and months to get mental health support. What's this chat? Oh, surveys. Okay. Any other questions, thoughts, things for me? Okay. Alicia, anything else that I didn't talk about that you would like me to cover?
I don't think so. I put in the link to the feeding and swallowing clinic that was on our website so they can get some more information. And then there's just that satisfaction link too, if they want to complete that. But I think you touched upon everything. If they don't have any other questions for you.
And I put the CED number and just Mackenzie. So if you have questions about referrals, or you've made a referral and you haven't heard back, or you just want to know more about the process, calling Mackenzie is probably the best way to get me as well. She'll track me down, or you can send me, I'll put my email. You can also send me an email. We would love to connect and work with families. We train other therapists, like just in training, or we'll collaborate, whatever that looks like, just so we can kind of help. Feeding is a gap in our state. So there's one other multidisciplinary clinic, it's at Marshall, but they require insurance. And so sometimes if insurance coverage doesn't work out, Dr. Holland is the director there. She's fantastic. Then they'll end up coming to us just because of insurance kind of things. So check out Marshall too, if your family has insurance and you guys are in the southern part of the state. They're a great resource as well. Okay.
All right, well, if there's no other questions, thank you so much, Cassie, for speaking with us today.
Oh, sure.
Our next session that we have for the virtual speaker series is October 14th, and it is with Jenna Wallace and Claire Bainick from Unlock Potential. So, and they're going to be talking about early autism. So
Yes.
join us for that. All right, well, if there's no more questions, everyone have a great day. Like I said, there's all kinds of information in the chat now, the emails, phone numbers, and the CED information.
Yep.
So-
And feel free to give me a call if you want to chat.
All right, thank you guys.
Bye.